Okay, so basically this case is all about how you really diagnose and how you really manage a patient of ARDS coming to your ICU. This is something which is very, very practical and you should know, and I would like the participants here to ask questions, because we have put forward few of the questions, but you may have some subtle doubts, and those subtle doubts really make the difference in your patient's outcome. Okay, so we have this patient, Yash, who is 52-year-old, bank staff, non-smoker, chronic alcoholic, diabetes for the past 10 years and uncontrolled. Patient is also on steroids and immunosuppressants for connective tissue disorders. There's no history of any hypertension or coronary artery disease, old pulmonary tuberculosis or chronic respiratory illness. Vaccinated for COVID with 2 doses of vaccine, not vaccinated for influenza and pneumococcal pneumonia. He presents to you with complaints of high-grade fever with coryza for 5 days, non-productive cough for 5 days, exertional breathlessness from MMRC grade 1 to 4 for the past 3 days. There's no history of any chest pain, hemoptysis, loose stools, or abdominal pain. You examine the patient is conscious-oriented, respiratory rate is 40 per minute with use of accessory muscles of respiration, tachycardic with a pulse rate of 130 per minute, BP with 90/60 millimeters of mercury, and saturation is 89% on 15 liters of oxygen via rebreathing mask. And chest is suggestive of bilateral vesicular breath sounds with crackles. You see the ABG, and pH is 7.48, PCO2 is 30, PO2 is 52, and bicarbonate is 28 millimoles per liter. Now I'd like to ask Dr. Mishra sir, what do you interpret from this ABG? And how important ABG in this current scenario?
No, basically, I think if possible, students should answer this. Is it possible? Somebody can answer?
No, if anybody answers, the stethoscope is for you for this question alone. No, we'll give them, ma'am. It's not an issue. Is anybody who answer this ABG because you have listened to the first talk? Anybody, any volunteers? Nobody is ready to even answer for an ABG. Yes. Your good name? Tevan.
pH 1.48, so alkalosis.
Okay, good.
PCO2 came down. Bicarbonate increased. So
what is it?
Respiratory alkalosis.
Okay.
So for respiratory alkalosis, acute case, there should be compensation by 1 millimeter of bicarbonate. So normal bicarb is 24, so it should be increasing by 20. So decreased by 1 bicarbonate, so it should be 23, but it's 28. So both respiratory and metabolic alkalosis.
Yeah, very good. So, sir, Mishra sir, is that okay? So you have to see.
Obviously, hypoxia.
And what else is missing in this ABG?
Electrolytes, anion to calculate
Yes.
anion
You
gap.
have to look for the
Anion gap.
anion gap also. Very good. So a big applause for him, and he deserves a stethoscope for this. So okay, so we'll move on to Mishra sir. How important is ABG, and what are the precautions you should take while send Mike?
If you see any ABG, the first thing should be the validity of the ABG. Okay, the validity will come as 24 into PCO2 by bicarb. I am not very sure that it is valid or not. Okay, there is respiratory alkalosis plus metabolic alkalosis. Usually don't see together, but possible. But whenever there is a metabolic alkalosis, there should be respiratory acidosis as a EF. And both together, rare, but we need to see the validity to see first. Anyway, I can't calculate right now. If you see 24 into PCO2 is 30, by bicarb 28, just see how much it is coming. You can have a mobile, you can do it. So that need to be detected from 80, and that should be the next 2 digit after 7. If first thing you need to see the validity, then you see what kind of acidosis it is. Look at this 7.4, it goes in favor of a alkalosis. So if you see the CO2 is also 30, bicarb is 28, so there is a respiratory plus metabolic alkalosis in this case. And third thing is, whenever the PO2 is low, let's see 52 in this case, whenever there is a hypoxia, the next thing what
AO2.
we are supposed to do is AA gradient, alveolar atrial gradient, to see that where the problem is. If the alveolar atrial gradient is high or normal. If it is normal, then maybe there is like a patient is being high altitude or something else, not like pulmonary problem. So these are the basic things. Whenever you see ABG that need to be done, most of the people they miss with the validity of the ABG.
Yeah. So then you get an X-ray for this patient, and in X-ray you have got a bilateral lung infiltrates. So what is the provisional diagnosis in this case, and what would be the differential diagnosis for this patient as well?
If you see the X-ray and with the history and hypoxia, it looks like bilateral pneumonia. And with that PF ratio, which may be around 15 liter oxygen with a non-rebreathing mass, comes to around 60 plus 20 is about 80% FiO2. With 52 PO2 comes into the severe ARDS category. So most probably bilateral
the point of
pneumonia
putting
with
this
severe
is that
ARDS.
only, sir. Can you classify the severity of ARDS when a patient is on a rebreathing mask?
Not so, because we need to have some PEEP also,
Yes.
or CPAP. Without a CPAP of 5, we are not supposed to, as per the recent guidelines, as per the Berlin definition. But yes, patient is having severe hypoxia.
Yes. And what could be the ARDS mimics?
One addition to that. So if you see this month's American Thoracic Society, they have come up with the new global definition of ARDS, especially for resource income limited countries. So there is an addition of SF ratio, right?
SF ratio.
So you can use SF ratio also of more than 315 if you have. That is another criteria for defining an ARDS.
And right now, the recent guideline also has given a recommendation for HFNC.
Yes, more than 30 liters is a definition for ARDS, as well as there's been addition of usage of ultrasound. So, experienced hands-on ultrasound, if you have an ultrasonographer, that also can help you in diagnosing an ARDS. So these three different things, Berlin's has come in way back 2012. So
Yes.
now this has been added to the global definition.
So for the audience here, one, the standard criteria still remains you give a PEEP of 5, and then you calculate the PF ratio at 100% FiO2. That will give you the exact severity. But if you are in a resource limited setting where you don't have an access to NIV, then probably you can use the SpO2 by FiO2 ratio, or you can have, if you use the high flow nasal cannula, as Dr. Arun has, as Dr. Karthik has already said, more than 30 liters will amount to a PEEP of 5.
There's a small caveat there. Your saturation should be less than 70%, 97 or equal to 97, not more than 97. This SF ratio holds good.
And what are the, apart from ARDS secondary to pneumonia, what are the other causes of ARDS, and what are the mimics of ARDS? Because that is something which we should not miss, because not all ARDS is a secondary to viral.
Yes, we have transfusion-related lung injuries that happen. Then aspiration pneumonia can occur with your ARDS can occur because of that. You have inhalational injuries, toxicities that can present with ARDS, extra pulmonary infections, which lung can be an bystander to a total different pathophysiology as such. So there are many other conditions, or pancreatitis can also itself present as an ARDS. So these are some of the things that can present like an ARDS, but without the pathology being in the lung.
So for the postgraduates here, so you broadly classify the ARDS into pulmonary related and extra pulmonary causes of ARDS. So, and especially when it comes to the pulmonary causes, not all ARDSs are infectious. Sometimes you have diffuse alveolar hemorrhage, which is most commonly missed. Until and unless you suspect, you see the hemoglobin, or you do an ET secretion, or you do a BAL, you will think that it's just a viral infection. It could be a case of a diffuse alveolar hemorrhage. Any patient who is a recent vaping or recent smoking comes to you with an ARDS without evidence of other systemic manifestations of ARDS like a shock or sepsis, you should suspect acute eosinophilic pneumonia. Until and unless you suspect, you cannot diagnose an acute eosinophilic pneumonia. And third thing is, as sir has already said, transfusion, which is very common in ICU. Sometimes your patient might be improving. You are given blood overnight. You will not know. Next day you see the patient is having a transfusion-related acute lung injury. Sometimes there's something called TACO, transfusion-associated cardiac overload. Everything can cause ARDS. So whenever you see a viral pneumonia patient also, always think, don't immediately jump and say that it is viral ARDS. You can have so many alternative etiologies, and the most common mimic for ARDS in your ICU will remain a congestive heart failure. So until and unless you rule out a congestive heart failure or a fluid overload, never label your patient as a case of a ARDS. So then laboratory is done, hemoglobin is 12, TLC is 15,500, platelets are 2,80,000, creatinine is 1.2, LFT and 2D echo are normal. So pro-BNP is 900, COVID RT-PCR is negative, H1N1 is negative, and we do the film array panel, it comes as influenza A positive, blood culture and urine culture are sterile. Now I'd like to hear from Dr. Mona Lisa, ma'am. How good is the use of this biofire panel or the film array panel? And has it really substituted your role of ET aspirates in ICUs?
Considering this particular case, this patient presented with an ARDS. The film array definitely helps us in making an early diagnosis. The film array definitely helps us in making an early diagnosis, knowing the pathogens. But sometimes, like later in the course, if the patient is on ventilator, then we may get multiple organisms. So that time we need to put into context whether they are just the colonizers or they are true pathogens. And definitely they cannot substitute the culture, which is the gold standard. So if both of them corroborate, then we can definitely say it is a pathogen. If the patient is deteriorating, we may start on the antibiotics considering the biofire report, but definitely de-escalate according to the culture report.
And what do you feel, Mr. Sir, because you are an intensivist and
that's what I wanted to add on that. You see, film array is a PCR-based technology, so it can pick up even a dead virus or dead bacteria also. So the sensitivity will be too high when it comes to film array. They have some policies or some counts has to be there to say that it may be pathogenic. More so, if the patient is hospitalized for a period of time and received many antibiotics, colonization is a possibility. You can get multiple bacteria, viruses in the same film array report. In those cases, it becomes difficult which to treat, which not to treat. So that part is little difficult, but there you need to, that is the reason you have to send ET culture. It cannot be a substitute for a ET culture or maybe a BAL if the patient is, you are going ahead and do a BAL. Second thing is like in a community acquired pneumonia, in this case, the thing is, like, let's say you are sending H1N1 COVID, nowadays it takes 2 days, 3 days, we don't know. And the atypical organisms, those never grow. So let it be Legionella, Mycoplasma or Chlamydia, because you cannot grow in cultures. Those things most of the time will be missed. So we have seen a lot of Chlamydia, Mycoplasma and all when you do a film array. So film array can pick up those atypical organisms that cannot be picked up otherwise. And second thing is, maybe this influenza, para-influenza, COVID, everything can be picked up early. But film array, whenever you are doing in a patient who is there hospitalized for a long time, there is possibilities of multiple organisms grown in the same sample. There you have to take it more carefully.
Yeah, so basically it is a very, very useful test provided you use it in a proper context. So the advantages of using the film array is you get a rapid diagnosis, so you won't put these patients on unnecessary antibiotic. Let's say you get a frank virus positive, be it rhinovirus or be it influenza virus, and it clinically fits into your scenario. It helps you in rapid de-escalation of the antibiotics. But the problem with this is, as Dr. Mishra has already said, it has a very high sensitivity. That means even a dead virus or even a colony forming unit which is not that high will be picked up by your PCR. So you should always send your routine cultures along with PCR, but it is very useful for getting most of these atypical organisms which cannot be picked up by your cultures. So as we saw in this case, what is the severity of the ARDS? We almost had an answer. So moving on to just to show to the postgraduates here, this is the current definition for the ARDS. You need to have an insult within 1 week of the worsening respiratory symptoms. You should have an imaging. Without imaging, you cannot call a patient as an ARDS because your patient can have a lung collapse. Your patient can have a massive pleural effusion. So until and unless you have an imaging, you cannot confirm whether you are dealing with an ARDS. And the origin of the edema should be defined. Like you should not have a congestive heart failure or a fluid overload that has to be ruled out. And oxygenation, depending upon the severity, that is at a PEEP of greater than or equal to 5, you divide it into mild, moderate, and severe. When it is between 200 to 300, we call it as mild. When it is between 100 to 200, you call it as moderate, and when it is less than 100, you call it as severe. But the point to be noted is your PEEP should be greater than or equal to 5. So we put this patient on a CPAP, pH was 7.48, and the PF ratio at 100% FiO2 was 152, and the severity came out to be a moderate ARDS. Now, to Mishra sir, when you deal with a case of a moderate ARDS, would you go in for an upfront intubation, or is there a role of any NIV or HFNC in this case?
If the PF is around 150, so there maybe there is a role of NIV and maybe HFNC also. So HFNC is coming up in a big way after the COVID where we have used a lot of HFNC. But NIV, if the workup breathing is high and the patient requires some form of support, then you have to think of NIV because HFNC cannot substitute the workup breathing. It is not going to support the respiration. It can give some CPAP, and because of our humidification, it can ease your secretions and all will get thinned out. But it cannot support the ventilation per se. If the patient is requiring some support of ventilation, NIV is always scores over HFNC. And second thing, yes, 150, it is borderline. They say if it is less than 150, better to intubate a patient and ventilate instead of waiting them on NIV, because there are good amount of evidence when you don't intubate them, when their PF ratio is less than 150, they do worse than pulling them on NIV. So less than 150, better to go for intubation. More than 150, patient is relatively stable, you can try them on NIV, HFNC if the patient is not having significant workup breathing and you believe they don't require any form of support.
So in this case particularly, there is one point that this patient is a mixed connective tissue disorder on immunosuppression. So that is one point that is giving you a trial, a chance of trial of non-invasive ventilation. Had he not had these comorbidities, in a moderate ARDS, there is no clear-cut guideline saying whether invasive or non-invasive would be better. Mild ARDS, if you take Florari trial where you have done the HFNC study, those are oxygenations were far, far better than this patient. Right? In a mild ARDS, you have the luxury and option of selecting one of those non-invasive. But in a moderate, you have to be dynamic. You have to have a close monitoring. If you are starting an NIV support for this patient, you need to monitor this patient very closely because patients can deteriorate and delay with NIV can cause increase in mortality. So you should not waste time when you're keeping such patients on NIV support.
So the point to be taken is when you are dealing with a PF ratio, especially more than 150, there is still a role of NIV and HFNC, and the role is more justified if you are dealing with a patient of an immunosuppression. But let's say that you have a patient who is not immunosuppressed, PF ratio is exactly hovering around 150 to 160, and the patient is having an increased cardiorespiratory work despite putting this patient on NIV, you should immediately go for upfront intubation. You should make sure that the patient cardiorespiratory work does not worsen, especially when a patient is having a moderate ARDS and who is a non-immunocompromised condition, because in such cases, delayed intubations can result in worse outcomes. So in this patient, as we discussed here, the advantages of the HFNC in comparison to your NIV is, you would have seen so much of high flow nasal cannulas being used during the time of the COVID. The major advantage is it produces a humidified air. So one, it increases the patient comfort. Second, because of the humidity, the patient will have better clearance of the mucus secretions. So let's say that I am dealing with a case where there is a high amount of mucus secretion like a bronchiectasis or something. Then probably I can choose a HFNC over a NIV because I can help in maintaining a better humidification of the airways and better bronchial clearance. Another thing is it is more comfort for the patient. When a patient is not tolerating NIV or feeling claustrophobic, then in such patients also I can give a trial of HFNC before I consider whether the patient has to really go for an intubation or not. But whenever the work of breathing is very high, the NIV scores much better over the HFNC, and that should be preferred as the modality of the choice. So in this case, the patient was initiated on NIV, and after NIV, the respiratory rate and the work of breathing decreased initially, but on the day two of NIV, the patient continued to be in respiratory distress, but he was maintaining hemodynamically okay. So on day 2, the heart rate was 130 per minute, respiratory rate was 35 per minute, BP was on the borderline 80/60 millimeters, and saturation is 90% on 60% FiO2 and a PEEP of 5. But your ABG is suggestive of combined respiratory and metabolic acidosis. So, Dr. Mishra sir, do you have any particular scoring on how to, or particular guideline on how to monitor a patient of ARDS when they are on NIV?
To be little less specific, if somebody is on NIV, see somebody is on ventilator, you can just put the patient on ventilator and you can relax. But patient is on NIV, they require more frequent monitoring than the patient on ventilator. If somebody is on NIV, you are supposed to monitor them like maybe every half an hour to after starting, and after 2 hours again you do ABG. If you believe the workup breathing is increasing And second thing, oxygenation is not improving or carbon dioxide is increasing. In this case, you see carbon dioxide is increased to 46. It was 30 when we started NIV. Whenever on NIV carbon dioxide is increasing, that means patient is going into respiratory failure, and these are the cases where you can't wait further. You have to intubate those cases because impending respiratory failure now. Yes, there are scores called hacker and all, so where we can see like hyperventilation, there is a score called hacker where there are points also where we can see that NIV failure chances are there or not, but it is not widely practiced. So it is the clinical decision what matters most when the patient is on NIV. If let's say clinically patient is not improving on NIV and oxygenation or gas exchange, things are not improving, better to intubate them and wait further on NIV.
So the important take-home message for you is NIV is more labor-intensive, and a patient on NIV is to be taken care of more than a patient who is actually intubated. So generally we think that we put a patient on NIV, that's all, like we can wait and watch. No. Patients on NIV are the ones who will become more sicker if you don't monitor them properly. So whenever you put a patient on NIV, always make sure that you are around. And as sir has already said, you have something called as a HACOR score, where you look into the heart rate, you look into the acidosis, you look into the consciousness status of the patient, you look into the oxygenation, you look into the respiratory rate. And recently we have something called as a HACOR plus. So along with this, you also take into consideration the background reason for ARDS, like presence of pneumonia or cardiogenic pulmonary edema or pulmonary ARDS, immunosuppression or septic shock. And when you combine, you get a score like this. And this score will help us in determining when the patient can be changed from an NIV to a ventilator, and the monitoring should be as frequent, like 1 to 2 hours you have to monitor first. Again, you have to monitor at 12 hours or even at 24 hours of initiating the patient on NIV. So this patient had a very poor HACOR score, and the patient was worsening, as we saw from the ABG. So patient was put on mechanical ventilation and was initiated on invasive mechanical ventilation. To Karthik sir, what would be your initial setting when you put a patient of ARDS on mechanical ventilation as a routine protocol?
So we would intubate this patient and start with 100% FiO2 to start off with. But what is very important for all of you to take home point when you're ventilating in ARDS is protective lung strategy. Now, definition of protective lung strategy has been changing of late. So we have started with the ARDS trial where we always talked about low tidal volume, right? It's with the purpose that we don't want our plateau pressures to go high. We don't want the barotrauma to occur. So one specific and one very important thing that you should keep in your mind is low tidal volume. So these tidal volumes are decided with your body weight, the predicted body weight, and we start with somewhere around 4 to 6 mils per kg body weight of predicted body weight, and we give tidal volume, right? And the other thing is to restrict your plateau pressures less than 30, and then you have to use an optimal PEEP. Now, what is optimal PEEP? How do you determine it is a topic in itself. So this is the strategy that you will be applying. And mode does not hold good. Which mode you are using has not shown any benefit. Whether you use a pressure control or a volume control, the principles are low tidal volume and the optimal PEEP, and you have to maintain a plateau pressure of less than 30, right? This was the definition of protective lung strategy. But of late that we have been seeing that the concept of the tidal volume being same for all the patients does not hold good. So that concept brought into the concept of driving pressures, right? So of late we have been seeing that driving pressures have come up big time, and we are trying to maintain a driving pressure of less than 15, because one tidal volume does not suit everyone. It always depends upon what is your functional residual capacity, or in other words, it depends upon your compliance of the lung. So you have to vary your tidal volume with the compliance of the lung using your driving pressures. Now, I don't want to confuse you more, but now the respiratory rate has also come into a picture, right? So each aspect, rate, the PEEP, and the tidal volume. Earlier, we always discussed about tidal volume strategies. Now we have the respiratory rate also coming into picture, because more the number of times you are causing lung to expand and collapse, you are going to cause injury to the lung. The whole norm of ventilating an ARDS patient revolves around not causing excessive lung damage, not causing inflammation to worsen in the lung, at the same time maintaining a decent amount of oxygenation. You need not maintain a supranormal or an oxygenation which you are very happy about looking at your an ABG. So these are some of the strategies that you have to keep in your mind when you're ventilating the patient of an ARDS, right?
Dr. Mishra sir, so what are all the mechanical ventilator induced trauma which you will anticipate in your patient, and what measures you generally take to prevent it?
Just to add what Karthik has told, I think the next thing which is coming up is mechanical theory. In mechanical theory is like the amount of energy which you are giving to the lung will decide about the lung injury. So what we are discussing right now is ventilator induced lung injury. So you see, first thing is what Dr. Karthik told, barotrauma, the amount of pressure what you are giving, then volutrauma, and the third thing is atelectotrauma, where the repeated collapse and expansion of the alveoli itself can cause injury and release of lot of cytokines and chemokines, which again injures the cause the multiple organ dysfunction. So this is one thing. Actually, mechanical theory, what Dr. Karthik told, no, we need to, the respiratory rate usually we keep high in a ARDS patient. We target because we are giving less tidal volume. To have that proper minute ventilation, you need to keep the respiratory rate high to target your carbon dioxide and pH. We target the pH of more than 7.25. So if you are okay with that, even a pH of 7.1 or 2 also is good. Try to keep your respiratory rate bit on the lower side. This is what the mechanical theory is telling now. The more the energy which is supplied to the lung will cause more injury per se. So apart from that, mostly barotrauma, volutrauma and atelectotrauma are the three major things what we look at when it comes to ventilating a patient of ARDS.
So in the interest of the time, we will go through the case faster. So the post-intubation, the patient developed shock and was resuscitated with fluids and was requiring vasopressors. Echo was done, there was no pericardial effusion, good LV contractility, no MI. Post-intubation X-ray, there is no evidence of any pneumothorax or collapse. And bedside DVT screen was negative for DVT. So a provisional diagnosis of viral ARDS with severe variety along with septic shock is made. So we already addressed this. So patient was initiated on pressure control mode of mechanical ventilation. The PC FiO2 was 1 and the pressure control over, pressure support over the PEEP was 20 centimeters and PEEP was 10. And tidal volume was 380, which was adjusted to 6 ml per kilogram of ideal body weight, and respiratory rate is 26 per minute. But after 2 hours, you see that the saturation is only 88%, pulse rate is 120, BP is 90/60, and respiratory rate is 26 per minute. And ABG, there is a mild improvement, but still the ABG remains acidemic. So Dr. Mishra sir, what would be your next option at this point of time? Would you go for proning, or is there any relative contraindication that you cannot prone because this patient is having a shock status? Or
No, actually prone is really indicated in most of the cases when they are not responding to your proper ARDS ventilation and you believe the PF ratio is staying less than 100, it's better to prone them. Yes, somebody is requiring very high vasopressors. There, like, we are not sure like how they will behave when you prone them. If they are significant cardiac instability or hemodynamic instability, those cases proning itself is a relative contraindication. It's relative, it's not an absolute contraindication. If you believe patient is dying because of hypoxia, still in those cases also you can prone and try. But yes, if somebody is requiring very significant amount of vasopressors, mean dual or triple vasopressors, in those cases we try to avoid proning.
so we did proning for this patient, but after 2 hours, again the patient condition deteriorated and the ABG became more worse. So what will you do next? And Dr. Karthik, what is your experience with respect to ECMO in such patients? Do you really consider ECMO as the only rescue therapy, or you should continue more proning to see, because we have observed only for 2 hours, or you want to change into any other sort of ventilatory modes?
There's no evidence to say that changing mode or doing any other intervention in this scenario can help a patient to bring him out of mortality. So what the guidelines or what the literature says is you try with lung protective ventilation. If you're not able to achieve, give a prone trial. And prone trial also, you should see an improvement in prone trial. So normally in ICU, when we prone the patients, we give, if you see the Prosiva trial also, which showed improvement, 24 hours of support they have given in order to see whether it is achieving the required targets or not. But if you are not maintaining a PF ratio of more than 80, even with prone, for at least 3 hours, then you should really start thinking about ECMO support. And ECMO, when I say it is a veno-venous ECMO here, because we are talking about pure acute respiratory distress syndrome. So if you are not in a center which is enabled with ECMO, please do think about shifting this patient to ECMO enabled center. That has shown to improve mortality. And the second one is 3 hours of trial of ECMO and prone ventilation, and you see the PF ratios are not improving more than 80, then you should really think about considering your VV ECMO.
So we initiated this patient on ECMO, but another important question that really comes is, what is the fluid that should be given for resuscitation of this shock, Dr. Mishra? Would you still go ahead with normal saline, or you want to try some sort of a ringer lactate or plasma light or something like that?
Can I answer the previous question?
Yeah, please.
No, I think Karthik has told everything. Just to add few things. The main problem with our scenario in India when it comes to ECMO, and we start always late. Okay, we just ventilate them, we prone them 3 sessions, 4 sessions, 5 sessions. Then we'll take a call, okay, patient is not responding, now we should think about ECMO. That itself is very wrong. If you see the main two, there is no universal guideline at this point of time when it comes to ECMO, when to initiate. There are two main bodies. If you see, one is ELSO guidelines. They say if your PF ratio, what Dr. Karthik told, if PF ratio is less than 80 with a FiO2 more than 80, that is the time with a Murray score. Murray score, where they see there are 3 or 4 criteria are there, the average of that need to be taken. If Murray score is 3 or more than 3, so maximum score is 4. That means there is a significant lung involvement. In those cases, you have to start ECMO irrespective of the time frame. That is ELSO criteria. Whereas the EOLIA, they have given some little different criteria. They are more aggressive when it comes to ECMO. When the PF ratio is less than 50 with FiO2 of more than 80 for 3 hours, you need to consider ECMO in those cases. If PF ratio is less than 80, less than 50, less than 80, that is for less than 80 for 6 hours. So now they consider ECMO very early than late. At least you should think of ECMO early. And in this kind of cases where even if the patient is on vasopressors, but cardiac function is good, in those cases, it is always advisable to go for VV ECMO, not the VE ECMO. Till your cardiac function is good, you should go for a VV ECMO. If cardiac function is also involved, let's say patient is having sepsis, they can have severe cardiogenic shock also. In those cases, you have to consider VE ECMO. Otherwise, it is always advisable to go for a VV ECMO. Now coming to the fluid. So see, like fluid, any resuscitation of septic shock or most of the shock right now, it is the crystalloids, which is the drug of fluid of choice. When it comes to crystalloid, it can be a normal saline, ringer lactate, or maybe balanced salt solution like ringer lactate or plasma light and all those things, only the drug of choice, fluid of choice. And the amount of fluid need to be given as per your surviving sepsis guideline is almost 30 ml per kg as bolus. It should be given over an hour or 2. And when you are giving fluid, make sure to see 2 things. The blood pressure is improving or not, and lactates are clearing or not. In the meantime, if the blood pressure is so low, you are giving fluid, doesn't mean that you wait for an hour or 2 before to start your vasopressors. You can start vasopressor simultaneously. If you give fluids and the vasopressor are wind up, that is good enough. You should not wait for 2 hours when you are giving fluid. Now the blood pressure is not improving, then you are going to start any vasopressor is wrong. You should start vasopressor early. You give fluids. If the blood pressure is improved, you can wean off your vasopressor. That is what the new things what we need to do whenever. Not in this kind of sepsis, any form of sepsis, that is how it has to be treated.
So in this case, the ringer lactate was started. Now we did the endotracheal aspirate, and now the endotracheal aspirate is showing pneumonia panel PCR suggestive of NDM Klebsiella. Mona Lisa ma'am, like how do you really treat NDM Klebsiella these days? Like, is there any role of an inhaled antibiotic, or what is the antibiotic that we are going to offer to them? Or any further information you require when you are sending these labs for testing?
Along with the pneumonia panel PCR, we should be sending the sample for a gram stain and a culture as well. Then we get the reports of the PCR within a few hours, so that helps us. And the resistance pattern that is observed these days are most of our isolates, about 70% of them are carbapenem resistance. And the mechanism of carbapenem resistance is mostly in co-producer of the metallo-beta-lactam, is the NDM, MVM, and along with the OXA48. So for these bugs carrying both these enzymes, we need to be giving ceftazidime avibactam along with the aztreonam. Or even alone NDM producers, we need to give ceftazidime avibactam along with aztreonam, both being infused simultaneously over 3 hours.
So the important thing what you people should understand here is, unlike before, if you get Acinetobacter, it is not colistin. If you get Klebsiella, it doesn't mean that all will respond only to colistin. You need to look into the gene pattern also. For example, if you have a KPC, the drug of choice would be just a ceftazidime avibactam. The other two drugs are currently not available, relibactam and verobactam. But if you have a KPC along with an NDM mutation also in your whenever we send a pneumonia panel PCR, you will ask something called as a CARBAR to identify what is the resistance pattern. In that, if you get the NDM, then you should treat the Klebsiella with a ceftazidime avibactam in combination with a aztreonam. And if NDM is not there, then just your ceftazidime avibactam would be sufficient when you are dealing with a case of a Klebsiella. But let's say if you are dealing with a case of an Acinetobacter, then still your colistin or polymyxin would score over using a ceftazidime avibactam combination in such patients. So in the interest of the time, I am just skipping most of the things. And one last question to Dr. Mishra, sir. What is post-intensive care syndrome, and what precautions would you really take to prevent post-intensive care syndrome? And is it really important to understand that? Like your critical illness myopathies and neuropathies. Yeah, sir. Please go ahead.
I would like to further add.
Yeah, please.
We should be also sending for a expert CARBAR along with the synergy testing, because these days even ceftazidime avibactam resistance has also been documented. About 30% of the isolates of Klebsiella are even resistant to ceftazidime avibactam and aztreonam individually, but the synergy test means both of them when given together would be synergy. So the test also needs to be sent.
Now, anyone understood regarding what is that we are discussing, KPC, OXA and NDM?
The KPC enzymes are not there in our country. It is mostly in the European countries.
So these are different mechanism of resistance, what we see in ICUs or Indian scenario or any other. So you might have heard about ESBL, non-ESBL, VIM, IMP. These are all different enzyme producers by which one bacteria develops antibiotic resistance. So these are the things when CRE means carbapenem resistant, mostly Enterobacteriaceae, what we talk about. Enterobacteriaceae means Klebsiella, Pseudomonas and E. coli. Acinetobacter doesn't come in Enterobacteriaceae. That is what we are talking about. You see KPC, you see your NDM, and we see OXA. These are the three most commonly what we are seeing nowadays. But KPC is not common in India. What we see most often is NDM, and sometimes we see OXA. But NDM is maybe 70% of the time it is NDM, and 20% of the time it is both NDM and OXA48 or OXA series. Very few cases we have seen only OXA. When is OXA or KPC, ceftazidime avibactam will work. When it comes to NDM is there means only ceftazidime avibactam is not going to work. So there you have to have aztreonam. So ceftazidime avibactam has to be given when there is NDM. Plus, if there is no NDM, only OXA or KPC, what we don't see in India, there you can escape with only ceftazidime avibactam. Now, regarding critical illness myoneuropathy, what we are discussing. So this is a very common thing what we see in ICUs. Not only this patient who are on ARDS, any patient in ICU who is there for a long period of time, and more so on the patient who are on on ventilator requiring sedation, and maybe initial 1 or 2 days we give them muscle relaxants also. Those patients are very high probability to develop a critical illness myopathy. So sometimes they will have, usually when you should suspect is, see, the patient will not have weakness in one side. If somebody is developing, let's say, one-sided weakness, you need to think about a stroke only. You should not think about a myopathy. When you are thinking about a critical illness myopathy, all the limbs should be equally affected. It has to be universal. It should not be unilateral or something. If you see hands, legs, everywhere it is affected, mostly the proxial muscles which are involved more than the distal ones, you should think about a myopathy. But it's common, and maybe because sometimes we give steroids in ARDS patient, we give muscle relaxant, and those things may propensate further. But it is a common thing. Any patient who is on ventilator for more than 5 to 7 days or 8 days, there is a probability that they can develop. And that is the reason we need to do aggressive physiotherapy and all those things when the patient is on ventilator also. That is one of the things by which we can avoid, and nutrition is the second most important. That is, you should give good amount of proteins to these cases.
Any questions from the audience?
And
one more important thing, apart from this, there's a very important component which is most often we forget is cognitive behavior disorders. This is very common till the first 6 months patient recovers from a severe ARDS, right? So to avoid these cognitive disorders occurring, there have been strategies in your sedation that you implement when you are ventilating patients with ARDS and post discharge follow-up for 6 months, right? So that also comes under this category, right?
So if there are no further questions, thank you panelists for enlightening the students about all the aspects related to the critical care. Thank you, ma'am.